I can still remember the first time that somebody put an IO needle in my hand. I was a third-year resident and we had a pretty sick kid. People had been fumbling around trying to get an IV in. And then one of the old school attendings drops a Jamshadi needle in my hand and said, "Put it in the tibia." And we put it in, resuscitated the kid, and all ended up pretty well. And I remember falling in love with the device right there. This was the easiest thing I had ever done to gain access in a patient, especially when you have that kid who is crashing and just needs access so you can get started on that resuscitation. And of course, at the time, we didn't have the commercially available drills that we have today. And so if we wanted to use these in adults, we could, but it took a little bit more force to get those in. Once those drills came out, this all went away. The thought of not using an IO to me seemed kind of foreign. I can get this quick, easy access in immediately, and I don't think twice about it. But as much as I love IOs, I think it's also important for us to look at the limitations of these devices when we're using them so we know how to use them, when to use them, and then also when to replace the IO with something else. The first rule that I have lived by with IOs is the sicker the patient, the more likely the IO is the answer. If the patient is really sick and crashing, I can get that IO in way faster than someone could put in an intro or an IV or a central line. There's no resuscitation medication or blood product I can't give through the IO, and there's no risk of me getting an arterial stick where I then have to withdraw and reposition in order to get into a vein. In the patient with cardiac arrest, there's no question. Put the IO in and be done. Whatever resuscitation meds you need to give them through the IO. There's no reason to bother with a central line or an intro or an IV. And I feel the same way when I'm thinking about hemorrhagic shock. If I've got that trauma patient who's bleeding out, who is really sick in front of me, I'm going IO first. One of the limitations you do have to think about in trauma is you don't want to put this into a bone that is fractured proximally. That's not really going to help very much with getting whatever meds you want or blood products into the patient. But aside from that, these are great devices for acute resuscitation. You can give blood products through them. There is some literature that says that maybe you get a little more hemolysis. It doesn't seem that there's any data to tell us, though, that that affects clinical outcomes. So the IO is the way to go in the cardiac arrest, in the massively bleeding trauma patient for that immediate access. The other place where I find these to be really powerful is in that sick pediatric patient, just like the case that I had when I was a third-year resident. The sicker that kid is, the more likely the IO is going to be really useful because kids can be really challenging to get access even when they're not sick and dying in front of you. So in the sick and dying kid, it is IO first. And what if you have a kid who is sick but not immediately crashing in front of you? Well, I think here you can try to get an IV, but the mantra we should have in our heads is 1-2 IO. In the sick kid, you get 2 shots with an IV, and then I'm putting in the IO. What I've seen many times, and I'm sure you've all seen it too, is someone saying, "Oh, I'm almost there. I'm almost got this IV in." All of a sudden, you're in 20, 30 minutes into taking care of that kid, and you still don't have access. 1-2 IO. You get 2 sticks, and then I'm drilling the bone with the IO so we can get this kid resuscitated. Another important aspect to think about with IOs is location. Location is really important here. There's a lot of different places we can put these in. In kids, typically we're going proximal tibia, distal femur. You can go distal tibia as well. In adults, there's even more spots where these can go. In addition to the proximal tibia, the distal tibia, you can also put this in the proximal humerus, and that's actually a great spot to use these. One other place to think about putting these is in the sternum if you have a sternal IO device. You can't do this with the commercial drills, but there are devices that are specifically designed to put an IO in the sternum, and they are fantastic. The location is important because of the flow rate you get with that location. If we look in adults, there are some cadaver studies with pressure bags showing that the 5-minute bolus for an IO in the tibia is about 200 cc's. Not bad. In the humerus, it's about 300 cc's. A little better. If you have one of those sternal IO devices, we can actually give about 500 cc's over 5 minutes with a pressure bag. So that is a lot of volume that we can give in a short period of time. And again, if volume is important specifically in the patient who's bleeding out, then you might want to think about the location you're putting that IO. Of course, the different locations also come with some downsides. Sometimes the sternum, the humeral area are places where you can't get to because there's a crowd in that area doing other things. This is where the proximal tibia is really powerful. There's usually not a lot of people around the legs during that resuscitation. And of course, if you don't have the sternal IO device, that's not going to be the spot that you're putting one of these in. While the proximal humerus is a great place, has a little better flow rate, there are some downsides there too. It's a little bit of a harder place to put your IO. You really need to internally rotate that shoulder, locate the humeral head, and then aim your IO at that spot. And depending on how much extra tissue the patient has, that may be less or more difficult. That's why the proximal tibia is often our go-to site. Typically, that's a much easier spot to find. If you go with the proximal humerus, one thing you have to make sure is to keep that shoulder internally rotated. Internally rotating it to find the humeral head for placement is important, but also maintaining that internal rotation or you will get dislodgement. So once you put that IO in, if you externally rotate that shoulder, it is much more likely that your IO will fall out. Cliff Reed published a nice little cadaveric study looking at exactly this. External rotation makes it more likely you bend the needle. And so if you need to move the arm away from the body, like say to put something like a chest tube in, you want to keep that shoulder in internal rotation as you abduct it from the body. And of course, we'll drop a link in the show notes of the article so you can take a look at exactly what's going on here. As wonderful as the IO is, it is important to know what the limitations are. You can't really get the labs that you want off an IO. You can get blood, you can send it, but in general, the things that you really care about aren't going to be accurate. And so you want to actually get a stick to send labs off. The IO only has a single lumen, so that can sometimes limit how many meds we can give. But remember, you can put multiple IOs in, and I have done that in the middle of a resuscitation. And probably the biggest limitation is dislodgement. These are not a secure line like if you sew in a CVL or an intro. And so I will use the IO for my initial resuscitation. Once I get to a place where either the patient's more stable or I've got a couple more bodies, then I'm going to want an intro or a central line because I can sew those in, making them a more secure spot for me to give my medications throughout the rest of that resuscitation. But despite those issues, the IO is extremely powerful in the acute resuscitation, whether that be cardiac arrest, traumatic hemorrhage. If it's a medical issue, especially in pediatric patients, the IO is extremely powerful. We should feel comfortable with using these, but also know that once the patient becomes more stable, let's switch it over to a line that's going to be more secure that we can continue to use for ongoing resuscitation.
Thank you so much, Swami. A little bit more about IOs. The indications for IO are generally for patients who are in decompensated shock if peripheral IV attempts fail or if IV access takes longer than 90 seconds. Only 90 seconds. So the most common pitfall is to wait too long to place the IO. The sicker the patient, the more likely you'll consider placing an IO, as Swami was saying. There's really 4 limitations IO, some of which Swami touched on. Number 1 is you can't place an IO in a bone with a proximal fracture, a previous IO placement attempt, or any circulatory compromise proximal to the site. Number 2, labs are not going to be accurate, so once your patient has been resuscitated with the IO, you can then do your usual blood draw. The third limitation of IOs is that dislodgement really is common, so in order to avoid dislodgement, it's really best to use the stabilizer that comes with the IO kit as soon as possible. If your kit does not have a stabilizer for whatever reason, stack lots of gauze on both sides of the IO and then tape it all down. The fourth limitation of IO is in little babies. IOs are only suitable for term infants who weigh more than 3 kilograms, so forget about using IOs in those tiny preemies. The other debate is which site is best. Now, there's essentially the proximal tibia and proximal humerus that are the most commonly used in the ED. In the military, they use sternal, but that scares the daylights out of me because there's a chance that I'll go through and through the bone, then into the pericardium, and then eke into the heart. So it's basically humerus or tibia. And I think tibia is the easiest to landmark. And I'm usually putting these in when time is of the essence. So tibia is my go-to. And it's my go-to even though I know that you can get faster infusion rates at the humeral site. If you need high infusion rates, say for someone bleeding out, consider multiple IOs. Usually I'll go for bilateral tibia. And then if I need more IOs, then I'll go for humerus. And as Swami mentioned, one big disadvantage of the humerus site is that you need to keep the arm internally rotated the entire time that you need that IO to be working. So if you need blood draws or an IV, that arm is out of commission. And as soon as that arm is externally rotated, your IO is popping out. One other thing that's important to know about IOs is how best to choose the needle size. So there's 3 weight-based sizes, but most experts agree that it's better to choose the needle based on the estimated distance from skin to bone. In other words, the amount of soft tissue. It's better to overestimate than to underestimate the needle size based on this distance from skin to bone.